Okay, so in any case, again, thank you for a very kind introduction, I want to focus on hematopoietic stem cell expansion in the setting of umbilical cord blood. Certainly, it's always difficult to follow Dr. Atala, who is done so many things in regenerative medicine, but in this particular case, we're going to focus on cord blood specifically, since I know that's been an interest also in China. In terms of trying to improve upon the results with patients undergoing hematopoietic stem cell transplantation for various malignancies and non-malignant disorders. Okay, so now my slide is not moving. Oh, there we go. So before getting started, there's need to have a couple of disclosures. One is that some of this work was funded by Novartis, and part of this was funded by Magenta Therapeutics. And I serve as an advisor to Magenta Therapeutics. So that's just to be aware of as we discuss the trials. So as many of you know, umbilical cord blood transplants has been around for about 3 decades. And an analysis of transplants done at the Fred Hutchinson Cancer Research Center in Seattle and the University of Minnesota back in 2010, we compared the different stem cell sources to see how they look compared to one another in terms of the survival. And what I think you can appreciate here is that in the setting of umbilical cord blood transplants, where the majority of patients received mismatched, very mismatched cord blood, the results were comparing quite favorably to a matched unrelated donor, and actually seemed to be superior to a matched sibling donor, at least in the context of the diseases for which we were looking at, which were predominantly acute leukemias. Now, in 2017, we evaluated the impact of conditioning regimens in the context of cord blood transplant. And what we were able to discern, interestingly, is that in the context of cord blood transplant for acute leukemia in children, we found that the regimen of TBI 1320 centigrade, fludarabine 75 milligrams per meter squared, and Cytoxan 120 milligrams per kilogram was superior to all other regimens, at least as those listed in the CIBMTR. Now, this is several years ago, but still, what it showed us is that with umbilical cord blood transplant, you could have a 70% survival at 5 years, with all patients being alive beyond 5 years after their transplant. So the next question is that, despite these positive findings, we still have a major barrier, that is slow neutrophil recovery and an increased risk of graft failure. And if we could overcome these obstacles, we might be able to markedly change the outcomes with cord blood transplants and make it even better than what it already is. So as you can see here, in an analysis that Mary Eapen and myself had performed several years ago, we compared matched and mismatched peripheral blood stem cell transplants with bone marrow that was matched or mismatched versus cord blood. And I think you can easily appreciate when looking at time to neutrophil recovery, it's much more rapid with peripheral blood, intermediate with bone marrow of 18 days, and then cord blood comes in at 25 days in adults, but with also a 15% greater risk of graft failure. So if we could overcome these major complications with poorer engraftment with cord blood transplant, we might be able to really improve the overall success rates of umbilical cord blood. So another piece of information that we all knew, and this is based on our own data at the University of Minnesota, one of the early analyses back in 2002, we simply looked at all patients, and at that point there were 101 cord blood transplants performed at the University of Minnesota, and we simply looked at what was the impact of CD34 cell dose. Again, you can easily appreciate this, is that those patients receiving the highest cell doses, just based on quartiles, you see that the time to recovery was 14 days, in contrast to a time to recovery of 30 days for those patients who were receiving the smaller grafts. So this would suggest to us that if we could just increase the numbers of CD34 positive cells, it might result in a better outcome. And this led us down the path of thinking about what's the possibility of ex vivo expansion culture as a way of solving the engraftment barrier. I should also ask you, are you able to see the pointer here? Can you see the arrow?
Yes.
Okay, good. So in 2008, a research team at Novartis performed an unbiased screen of about 100,000 more compounds to see which, if any, would result in expansion of the CD34, CD133 expressing cells in culture after 5 days with stem cell factor, FLT3 ligand, IL-6, and thrombopoietin. And one of the compounds, I'm sorry? Okay. Well, with one of the compounds, you could actually see expansion of this double positive population after 5 days of culture, and perhaps more easily shown here, where you see that after 5 days in culture, 53% of the cells still co-express CD34 and CD133. As it turned out, this lead compound was an Aryl hydrocarbon receptor antagonist, and it was subsequently called stem regenin 1, and you can see the molecular structure here. So the first step in all this was to then go and verify, the proof of concept that this would enhance engraftment, at least in the NSG mouse model. And simply put, what we did in this left upper hand panel was to compare different doses of cells, but I'm going to focus on just a few. One was looking at 300 CD34 positive cells after SR1 expansion culture, and we compared to uncultured cells at varying cell doses, and also cells that were exposed to the vehicle control, that is the stem cell factor, FLT3 ligand, IL-6, and TPO. And you can see here that with the 300 SR1 expanded cells, we had a very rapid recovery in engraftment, and it persisted over a period of 13 weeks, comparable to 10,000 uncultured cells. When we did limiting dilution analysis, we were able then to verify that there were a 17-fold greater number of SCID repopulating cells in primary transplant recipients as compared to the controls, and 12-fold greater SRC in secondary recipients. So this provided us with a proof of concept that we did have an early engrafting cell that would perhaps speed recovery, at least in the early wave, and persist long term. So the second thing that we want to do is to verify the safety of this before going into clinical trials. So one thing that we did was, after this massive expansion of cells, we thought, well, we better look at telomere length. And what you can see here, I'm just going to come down to the bottom part of the left-hand figure. And what you're seeing here is that in this bottom figure, this is the telomere length after expansion culture, comparing to other conditions, but also comparing it to mobilized peripheral blood. And I wanted to point out that even after expansion culture, the telomere length was still longer than in the mobilized unexpanded peripheral blood that you would have used for transplant routinely. What this also demonstrated that there was a 0.5 to 0.7 kilobase pair reduction, suggesting that there are approximately 10 divisions that occurred during the 15 days of culture. So that was important to know. We also demonstrated that in all the practice experiments, there was normal cytogenetics, there was sustained hematopoiesis in the non-SCID recipient, there was absence of malignant transformation in the in vivo model, and also after washing, there were negligible amounts of SR1. And we did some pharmacokinetic studies and dynamic studies in non-human primates, and we studied SR1 at a significant extent, but I'm not showing you the results here today, but they've been previously published. So the rationale for this hydrocarbon receptor antagonist testing in clinical trials was at first to maximize the safety for the patients. We then developed a strategy where we used the double cord blood platform such that unit 1 would be the better of the two units, and it would be left unexpanded. The second unit would be placed in expansion culture, but this would be the lower dosed cell unit. So we were giving the advantage to unit 1 that was unexpanded. And we did that as just in case that unit 2 had stem cell exhaustion or it was impaired in some way, at least there was a good chance that unit 1 would engraft by itself. So if we demonstrated safety in this phase 1 use trial, then we would go on to a phase 2 trial using the expanded product as a standalone graft. So you have to go back now to 2012 when these studies began, and the general convention for HLA matching was still looking at 6 antigens, looking at A and B at antigen level and HLA DRB1 at allele level. What we also knew is that there was an interaction between cell dose and HLA match, such that where the more mismatched patients, we required higher cell doses. So I think you see here, a 6 of 6 match, we required 2.5 to 3 times 10 to the 7th nucleated cells per kilogram. But with 5 out of 6 and 4 out of 6, we required increasingly high cell doses because we knew that there was an interaction with cell dose that would improve overall survival. So in this example, I think you can see here that based on these criteria, that in this particular group of examples, the 4 out of 6 HLA matched cord blood unit would provide us with the appropriate number of nucleated cells. And this would have been the preferred stem cell source, at least the way we did at the University of Minnesota and how we did these first clinical trials. So in this first clinical trial, expansion culture began on day -15, as you can see here. The smaller of the two units was first CD34 selected. The 34 positive cells were placed in expansion culture, as previously described, and the 34 negative cells were recryopreserved. After the conditioning regimen was given, and this is Cytoxan, fludarabine, and TBI 1320, what we did is we first infused the uncultured unit on day 0. 4 hours later, we infused the expanded culture. And then the following day, we gave the T cell containing CD34 negative fraction. The reason why we did that is because we wanted to see whether or not there were any infusional toxicities associated with the expanded product. And that was the reason for delaying giving the T cell containing fraction till the next day. Now, I should also point out to you, in terms of terminology, MGTA456 is the name of the expanded product, as well as its companion CD34 negative T cell containing fraction. So it's the combined of these two parts. And then we also were looking at the different doses, because after expansion culture, the numbers of nucleated cells possible per kilogram were running among the largest that had ever been given to a human. And so we did this in the dose capping method, such that we would have 4 dose ranges, and then we would look at the overall safety profile at the maximum tolerable dose. Well, the first step is now for these first 18 patients, what we were able to demonstrate is that with a starting number of only 4.4 million CD34 cells, that is total, not per kilo, then after 15 days in culture, we ended up with a product containing a median of 1.4 billion CD34 positive cells, or a 330-fold expansion. The cell dose for a CD34 cell dose was 17.5 million per kilo, and that compares very well compared to the typical umbilical cord blood unit, which only contains 0.2 times 10 to the 6 CD34 per kilo on average. You can see we lose some of the T cells, but the T cell dose was about 3 in contrast to the average of about 6 to 8 that we typically give with a typical unmodified product. But I also want to point out to you here that we looked at varying subpopulations of the CD34 positive cells. But let me just focus on this one. This is the CD34, 133 positive, 90 positive, the putative stem cell fraction. And there we even had a 100-fold expansion. So we were quite happy with these results and moved forward to the clinical trial. Now, this has been previously reported in Cell Stem Cells several years ago, but I want to point out to you that what we were able to demonstrate was indeed that the MGTA456 was successfully engrafting long-term at a median of 10.5 days for neutrophil recovery. And although not shown, it was true for platelet recovery as well, that the time to recovery was quite rapid. Now, in some of the patients, the unmanipulated unit eventually won out. And as you may recall, in the double cord blood setting, we have 2 vectors that attempt to reject each other. And I'll show you some data that proves that. So what happened with these unmanipulated, the reason why these unmanipulated units won out was because of active rejection against the MGTA456 and not due to any inherent flaw within the MGTA product. And I'll show you that on the next slide. What we did here is that we looked for evidence of T cells that would react against the opposite unit. And what we show here is that on day 14 to 28, we would obtain peripheral blood from the patient that was previously transplanted, and then we'd incubate those cells with, against an LCL line that was from unit 1, one from unit 2, which was the expanded cell line, and then also the third-party lymphoid cell line. And then what we were able to look at was percent of interferon secreting cells, and this would tell us, the mechanism of why we observed what we did. In this particular example, on patient 9 at the bottom left-hand corner, you can see that we saw interferon gamma secreting cells directed against the expanded unit, resulting in rejection of the unit, and the unmanipulated product predominated. This occurred in only a minority of the cases, but the majority occurred here, where the MGTA456 was the one that predominated. To make a long story short, these data were sufficient to allow the FDA to give us approval to use MGTA456 as a standalone product, not only because there was a lack of infusional toxicities, but also because engraftment was rapid and durable, despite the fact that there were relatively few CD3 positive cells important in that immune rejection phenomenon that I previously described. So that was the safety data that now allowed us to go into phase 2 testing. Now, the phase 2 testing has not been published before, but something that I'm going to just describe briefly. Everything is exactly the same as what you saw previously, other than the fact that we didn't have the second unit. And these patients are receiving the graft as a standalone unit by itself. The expansion was 406-fold in this particular experiment. And you see the T-cell recovery is superimposable with what we previously described. And the primary endpoint is no longer safety. The primary endpoint now is looking at hematopoietic recovery. Once again, as a standalone unit, we have markedly rapid engraftment in terms of neutrophil recovery compared to the historical control, with about 11-day faster recovery than what we saw previously in 121 patients receiving an unmanipulated graft. So that was encouraging, and we had no graft failures so far in any of the studies. We then looked at whether or not there was a relationship between CD34 cell dose and the time to neutrophil recovery. And certainly the patient numbers in this first phase 2 study was certainly small, but what it suggested to us is that, well, despite all patients engrafting, it looked like that those receiving the higher cell doses, the y-axis being the cell doses based on CD34 expression, you know, if they had a dose exceeding 10 million per kilo, they seemed to do pretty well, all engrafting in less than 14 days. So in the future, that would become a target that we would go after, which I'll explain in a few moments. In terms of overall chimerism status, looking at the CD3 T-cell compartment versus the CD33 myeloid compartment, and looking at days post-transplant on the x-axis and the percent chimerism, percent donor cells, you can see with T-cells, first off, the MGTA456 patients are shown in red. The historical control is shown in this green-blue color. You see that very rapidly, the T-cells become complete chimeras. The myeloid cells are always complete chimeras. So this was a good outcome. In terms of graft versus host disease, chronic GVHD, relapse, and survival, what we can tell you is that they were all pretty much the same as the historical control. MGTA retains the benefits of low risks of GVHD and a good survival, but certainly after expansion culture, we did not see improved survival, despite the fact we saw improved engraftment. So that made us ask a few questions that I'll get to in a few moments in the most recent study, how we approached that. But just to be complete, in this first phase 2 trial, we also looked at the non-myeloablative setting where patients received Cytoxan, fludarabine, but only TBI 200, and in some cases received ATG if they had not had a recent chemotherapy. Everything else is the same in terms of the expansion culture methodology, and in this case, there was a 274-fold expansion of the median infused dose was 13.4 times 10 to the 6 per kilo. And the hypothesis this time was T cells are probably more important in engraftment in a non-myeloablative setting, and that made us concerned about whether or not there'd be sufficient T cells because with the cryopreservation of the CD34 negative fraction, there would be fewer cells. But as it turns out, engraftment is still not a problem. In fact, it's even better. There was a median time to recovery of 7 days versus 17.5 days in the historical control. So that was encouraging as well. Clearly, there's a beneficial effect in neutrophil recovery despite what kind of conditioning we give. In this case, however, almost all the patients received either about 10 million per kilo or above 10 million per kilo. And you can see there is no dose relationship, at least within the numbers of patients we've had so far. But this is quite encouraging and uniformly engraftment was rapid with all engrafting before day 14. Chimerism, however, was a bit different in the appearance. Again, magenta, the patients receiving MGTA456, the expanded unit, are shown in red, and you have the control patients in green. And you see that it takes a bit more time for complete chimerism, but certainly by day 60, for all intents and purposes, the red or expanded product they were completely chimeras. There was one exception here where one patient at day 180 relapsed, and you can see that chimerism went down to 0. So once again, we're now looking at acute GVHD, chronic GVHD, relapse, and overall survival. They're all pretty comparable with the exception of chronic GVHD, where there was no chronic GVHD in this particular group. You have to remember that in the patients receiving a non-myeloablative PrEP, not only are they higher risk for relapse, but they're also at higher risk for GVHD because they're an older age group. But nonetheless, the results were quite favorable considering the differences in the populations. But then nonetheless, this was our background data for the upcoming trial, which I'll describe in principle. So in summary, the engraftment of MGTA456 is also rapid and durable as a spike conditioning. 36 of 36 recipients had engrafted now, so increasing the numbers that are engrafted. An infusion of 10 million per kilo of CD34 positive cells seemed to be a benefit, providing us with less than 14 days of engraftment after a myeloablative PrEP, but no such relationship existed with non-myeloablative conditioning. So we then asked the question, can we improve upon the HLA match? Because if we can give so many cells after expansion culture, can we start selecting smaller units? Because if we don't have to be, if we're not stuck with a minimum threshold of 3 × 10⁷ nucleated cells per kilogram, then perhaps we can find better matching. And in fact, in this one example where we have an 80 kilogram adult in this make-believe example, what you can see here, this is the number of units in the NMTP cord blood searchable inventory. And these are a number of cord blood units. You can see that most of them, the median number is about 1 billion cells. And then for an 80 kilogram recipient, if we require 3 × 10⁷, this means we need just over 200 × 10⁷ cells for this graft to be chosen. This is only 4.3% of the cord blood units in the inventory. But if we can reduce this cell number, then this could be an marked advantage because now we just need to have this number of cells, meaning that 75% of the units would be available to us and potentially improve the matching for that adult recipient. So in this next phase 2 trial, we had a hypothesis that we could reduce this cell dose threshold from 3 to 1 × 10⁷ nucleated cells, and this would allow us to get a better HLA matched cord blood unit. And while smaller starting cell doses may reduce the final CD34 cell dose in the product, we believe the expansion culture was robust enough to be able to consistently achieve a dose greater than 10, which was our target for faster engraftment. So our cord blood selection criteria also had changed a bit over the years. And so this trial began in 2019. And you can see here that we're now looking at allele level typing at 8 of 8 antigens. We're looking at different cell doses because by trial design, we lower the cell dose threshold to 1 rather than those increasingly high cell dose thresholds with increased mismatch. And so in the past, we would have chosen this unit as previously described, and now we would choose this unit if that cell dose was available with that degree of HLA match. So in this particular case, the overall structure of the trial with a myeloablative conditioning is the same as what you previously have seen. But another variable was that we're now looking at cryopreserved products rather than fresh products as we had done in prior studies. The primary endpoint, once again, is neutrophil recovery. So let me tell you some interesting results. And I'm only going to share part of the results so far because of the fact that the study has just ended and has also been submitted as a presentation at the American Society of Bone Marrow Transplant. And so what I'm showing you here is that in blue are the pediatric patients, and adults here are the adult patients. And look at, and this is now based on age, in order of age. This is an order of weight. And you can see this would be the original match and the new matching. To make a long story short, out of the 14 adults that were enrolled, 10 of those adults would have received a better HLA match graft, as shown here. And if you look at just those that are over 80 kilograms, all but one would have received a better HLA match graft. So while it has much less impact on children, certainly in adults, the fact that we can go to a much lower dose unit provided us with the opportunity of markedly improving the HLA match. So in terms of engraftment, although I'm not showing you all the data, I'm just showing you some correlations here, although you can make out some of the results. What we also were able to demonstrate in the patients, and there were 22 in this trial, although only 18 had been transplanted by the time this slide was made, you can see that there appears to be a correlation between time to neutrophil recovery or time to platelet recovery and the CD34, CD90 putative stem cell fraction dose per kilogram recipient body weight. You see these correlations here. So this is now an important biomarker in terms of potency of the MGTA456 product. In addition, I'm going to tell you that the risk of grade 2 to 4 GVHD was significantly lower, reflecting probably, or at least in part, the improved HLA matching that we observed. So in terms of survival, in terms of relapse, in terms of non-relapse mortality, I'm going to have to ask you to wait a little bit longer for that, unfortunately, because of the embargo of the presentation for the American Society of Blood and Marrow Transplant. But I'm going to show you just a summary here, and that what we can expect with various methodologies, whether it be UM171 or MSC co-culture or MGTA456 or Notch or use of NiCord with nicotinamide. You can compare the level of expansion between each of these programs. But you also need to keep in note that the number of days for expansion culture is variable, with the greatest number of days for NiCord, 21 days for the culture period, in contrast to 15 for MGTA456 and 7 for UM171. And days to culture is certainly a practical issue in the context of blood and marrow transplant. But also, we want to be able to shorten the time to neutrophil recovery. And while this is only 7 days, it still gives us a neutrophil recovery of 18 days versus the 10.5 to 15 as previously shown in 2 myeloablative trials, in contrast to NiCord, which is also 10.5. So these are all important pieces of information as you think about the opportunities with expansion culture. So in summary, what we can tell you is that inhibition of the Aryl hydrocarbon receptor in the presence of stimulatory cytokines is associated with marked expansion. Intriguingly, engraftment has occurred in all 54 of 54 patients who have received this treatment thus far, with recovery of neutrophils and platelets markedly faster than what they would have been with single or double cord blood transplant. And so far, there have been no late graft failures. The selection of cord blood units now we know can be significantly improved upon with better HLA matches because of the marked expansion that allows us to now look at grafts with far fewer cells than we previously looked at. So with improved cell dose and improved HLA match that is now possible with cord blood, we think we might be able to change the future of cord blood in transplant medicine.